Hello and welcome to Surgery 101. In this video, we're going to be talking to Dr. Javeed Sukhera about bias in the Canadian medical system. So welcome, Dr. Sukhera. We thought maybe we'd ask you about yourself first. So can you tell us a little bit about yourself?
Yeah, sure. I am a child and adolescent psychiatrist currently in London, Ontario, where I'm an associate professor of psychiatry and pediatrics. But I'm also a PhD scientist. So right now, half-time doing research in Western Center for Education Research and Innovation. And I'm the incoming chair and chief of psychiatry at the Hartford Hospital in Hartford, Connecticut this fall. I was born and raised in Toronto, Canada. I grew up the child of immigrants from Pakistan, parents who came in the 60s and 70s, and started off my academic career in Toronto at the University of Toronto. For medical school, I did something very unique and different, going to Israel, studying at Ben Gurion University as part of a unique program in collaboration with Columbia University focused on global health. Did my residency and subspecialty training in the US in Rochester, New York. And for almost a decade, I've been here in London doing various types of work, including clinical work in general child and adolescent psychiatry, as well as I am the psychiatrist in our pediatric chronic pain program.
And I guess what was that got you into medicine, or what was it that attracted you to do this work?
For me, it was when I was doing my undergraduate degree at the University of Toronto that I had a few experiences in global health. And I thought that that was what I wanted to do, to work in challenging international cross-cultural settings. And I was really drawn to people and the stories that people had and how to help people through challenge and adversity, but also kind of integrate things in terms of integrating arts and science in that support. So that's what led me to medicine, was an interest in global health. I ended up landing in psychiatry pretty late in my training, mostly because I felt like it was a unique part of the field where I could put my skill set to work. And then it gave space and time to really build a solid connection and trust a process to help foster healing.
I think a lot of the people that I end up enjoying talking to are people who have got different parts to their story, who have maybe trained in different places or have moved around a lot, or have moved from one place to another. Essentially, you need to get a bit of diversity in yourself, I think, in medicine.
Yeah, I mean, I agree with you 1,000%. I think a lot of my own work in teaching, training, and research really does speak back to transformative experiences in education, not when we're just filling the cup, but when we find ourselves in challenging situations where what we think we know has to be questioned. And I think for me, for sure, training and working in an environment, for example, in Israel, where I didn't speak the same language as many of my patients, really enhanced, I'd say, my interpersonal skills, my communication skills, and it set me up to practice medicine with a different lens. I also think that many times, even within groups, I talk to students and residents, that experience of being, for example, going through clerkship, where you cross through all the different parts of the hospital, and then into residency, where you sort of choose a side or a team, and you begin to miss out on all those different experiences where you get a chance to see things from a different perspective.
Yeah, I would agree. You've written a thesis on your topic, and in fact, you tweeted a little bit about your thesis as well. So tell us, what do you think people should know about bias in health?
I did indeed write a PhD thesis on a topic, and I think where all this came together for me was my entire life has been about trying to reconcile experiences in my personal and professional identities of being or feeling different. And I realized that, my interest in global health and cross-cultural medicine kind of was part of that journey. But actually, it wasn't until I was in the early years of practice as a psychiatrist that I began to bear witness within the Canadian system how much we actually dehumanize some of the people who come in to seek care. And what really struck me was the ways in which we dehumanize people with mental illness and substance use challenges, particularly in hospital environments. But what I was also struck by was how much of that was happening by people who I knew, people like me, people who had high expectations of themselves and one another. And I was very interested in education. I found myself in a role where I was building and integrating global and public health curriculum here at the medical school. And so I had worked towards maybe doing a graduate degree in medical education. And as part of my thesis, the idea I had was to look into bias and how to address bias as it relates to people with mental illness. But when I started leaning into that question about what happens when we sort of look in the mirror at our biases and how we have that difficult conversation with ourselves and each other, that master's thesis turned into a PhD thesis. And it gave me a chance to really dig deep to get a better understanding of how we have those difficult conversations.
Why do you think this resonated with you particularly? Have you encountered anything like this in your own training?
I think for me, I came into this work with a real interest in issues related to equity, cross-cultural medicine, racism, and I think like many people who have personal experiences, I think I'm more than welcome to share that. For me personally, someone of my identity growing up in a place like Toronto, for much of my life, there was a lot of messaging around Canada being a different place, a place where people were accepted, where there weren't biases and where there were no restrictions and opportunity. And in growing up, I had to reconcile that with actually lots of experiences of workplace discrimination for both of my parents, two educated people who I would say in many ways weren't actually in fully welcomed as their whole selves into the Canadian system. So I realize that now. That wasn't something I realized at the time, but it actually wasn't until September 11th that I began to really and truly appreciate what that means. I remember the day that it happened. I was at U of T in my second year, and I had a friend at the time who wore a hijab, and we were in the subway in Toronto, and a woman sat down next to us, looked at us in disgust, got up, and walked away from us. So really in those months and years following that event, I began to have to reconcile for myself what it means to be part of a community or society where people might threaten you, where you might be unsafe because of political violence, but also where people might think that you're a perpetrator of that. I leaned into that experience by going to Israel. I have a Muslim faith background. That was a very unique experience. That's a whole other podcast topic. But a lot of my own experiences in life were about trying to reconcile some of those tensions. And I think naturally, I'm watching the inequities with which patients of mine were treated, the dehumanization, the blaming, the shaming that happen in clinical practice and in psychiatry. I was drawn to getting a deeper understanding of how do we make this better? How do we actually improve things in the system and in society at large so that people don't have these kinds of experiences?
I had one of those transformative experiences where you go through life and you're so focused on your own story, right? And just things are happening and you're just carrying on living your life. And then you hear somebody else's story and you go, wait a second, that's not right. And people who are just as well trained as I was from different countries, from the wrong country or from the wrong medical school, they're not even able to get close to that door. Like they're not allowed to come in and practice medicine at all. They have to work as a taxi driver or something. So, and again, you kind of contrast that with this idea that Canada is a nice place and it's fair and it's full of people who really want to welcome you in. But when you actually get in the door, it turns out it's not as welcoming as you would think, especially if your face doesn't fit and if your skin is not the right color.
That's what I think we're all reckoning with in Canada right now. And it's the reality that so much of the Canadian identity has been constructed around a utopian fantasy impossible version of who we are. And that serves a purpose. The Canadian discourse around us not being that way is part of who we are because, I think psychologically it makes us feel better about ourselves. We often define who we are in contrast to to what's south of the border. And Canadians and myself, having been raised in this society and having lived in the US, continue to encounter people saying, well, how could you take a job in the US? How could you live in the US? Without really appreciating how problematic that kind of thinking is. But in Canada, we have a harder time, I would argue, looking in the mirror at ourselves and reckoning with our own biases and problems in our midst, because it challenges our sense of who we are. It challenges our identity. And if we're not that, then it actually makes people afraid because they wonder, well, what are we and who are we in relation to the rest of the world? And that makes issues around bias and racism in particular, I'd say particularly difficult in Canadian settings, in Canadian organizations, and in Canadian medicine.
How widespread do you think this bias problem is against, say, certain religions or certain people of certain cultures in Canada?
So I usually reframe that kind of question to say, all we do, all the work we try to accomplish should start with the default assumption that there's a problem that exists and that it's widespread, that every interaction that we have is influenced by implicit, so out of our awareness, and explicit and structural biases, because all of these biases are a product of our experiences and are a product of the ways in which individuals in society works. To say how widespread it is like saying, you know, how much oxygen is there in the air? Well, we need oxygen to breathe, right? And similarly, I would say our brains are constantly functioning with the residue of past experience. Everything we experience sensitizes us to what we experience now. And that's a normal human thing. But what we also know is that there is a stratification of power in hierarchy in accordance with certain social identities between and across groups. And it's when those biases combine with power differential to actually lead to harmful, counterproductive prejudice and discrimination, where things become a problem. And how widespread is it? Well, it depends on what your experiences are. We often don't see things that we don't experience, and that's part of our privilege. But I would argue it's everywhere. Even someone who might traditionally think of themselves as not belonging to a group that's ever seen or witnessed it, I would argue actually knows what it's like to be biased, to experience bias, but also to express it. And I use a simple analogy of, you know, in customer service, if you have a bad experience with a telecommunications company, if you're going to call them, you're going to be sensitized to being experienced that way again. I know when I've had to call some of these companies, if you check my heart rate or blood pressure before I make the call, it's pretty high because I'm sensitized to being transferred to a million people or to people not understanding what I'm going to say. And that to me is an example of bias. It happens to all of us across experiences and systems. It can relate to visible differences, but it can also relate to invisible differences. And it's part of who we are. It's baked into everything we do.
So pretty much if you're human and you're breathing, you're probably biased in some way.
Yep, absolutely. And every system and structure has biases built within it as well.
Should we be making people more aware of their biases then?
Awareness is key. I don't think we can actually address some of these problems unless we raise awareness. But I also think that something that I see that's very problematic is people think that that's all we need to do is awareness raising, that you can do a workshop or a training and then that's it, you've solved the problem. I think a lot of our research has found that it's not about checking the box, it's about a continuous and arduous process of learning and unlearning, of critical reflection, of raising awareness, of getting outside of our own heads and critically kind of interrogating our blind spots. And to do that, we have to work with others. A lot of it requires engaging with people, particularly people who have different perspectives from one another. But another big part of it is actually reconciling that we have flaws and that systems that we work within have flaws. That I think is the first step, and that's the hardest step to do. And research, we confronted people with their biases. We held up that mirror, and what we found was people had a really strong reaction to that idea. Health professionals argued, well, we can't possibly have bias because we're professional and we're objective. But, of course we have bias because we're human too. And I think why I was struck by that finding is because I've always believed that the path forward through all of this is to humanize one another. And I realized that there's actually something about healthcare where we dehumanize ourselves. We compartmentalize our identities as a form of self-protection. And so I think the path forward to raise that awareness actually requires accepting our human self as someone who's flawed, that's not going to be perfect, but that can get it better if we are willing and prepared to challenge our own feelings of being comfortable or feeling like we have power or control.
I think you're right about the whole admitting that you're flawed, like admitting that you make mistakes as a doctor. That's a bit tricky, right? Like, you're not supposed to do that. Like when I was in medical school, they didn't say that's okay. You can be wrong sometimes. The idea is to be right 100% of the time. So it's tricky if you're going to start to encourage people to explore that side of things. It could be slightly dangerous to do that in a system that's so rigid that doesn't allow that.
Exactly, and that's why we have to be asking ourselves, what purpose does it serve to be an emotionless cog in a machine? Well, what purpose does it serve, and whose purpose does it serve? What it also highlights is that this work to address bias, to improve equity, to be anti-racist, it requires organizations to make structural changes, to have people's back. I don't think we can expect anyone working in healthcare to be able to engage fully and practice as much compassion as they need to and should for every human they see without a system that gives that individual space and time to have compassion for themselves. It takes a lot of emotional, psychological, cognitive energy to see beyond stereotypes and labels and to see people you work with as individual, unique human beings. So for us to move it forward, I think we have to challenge our organizations to do better, but also remember that we're part of those organizations. And so we can be part of the kind of change that we want to see.
Yeah, I think you're right. It's somehow the organization has to push us gently towards a culture where it's okay to talk about these things. And in fact, it's sort of expected to talk about these things.
Yeah, I agree. I think it's normalizing it. That's the key, the idea of normalizing some of these conversations. But one caution I have, because I see a lot of this go awry, right? I see so many organizations and leaders read an article or a book and then come at the people they work with buzzwords that they actually don't truly understand. So if we want to normalize vulnerability, we want to normalize and humanize the people that work within our organizations. We also need our leaders to do a better job of being truly inclusive. So this idea around peer support, well, it's one thing to implement something because it's a buzzword or because other people are saying it or because you read about it in an article. And it's another thing to actually understand how people are doing, what words mean to different people, to dig deeper into the cultures that support or inhibit who we are, who we want to be. And that's an important part of this, as we can rely on organizations to make that change, or we can be part of that change. I also think we should be digging deeper and not just making change because it's a trend or because people are talking about it, but really think about what kind of medical system do we want? Do we want people working in a system where everyone is able to show up as their authentic self and give their fullest and feel connected and feel like the system that they're working in has their back, or not? Because that's something I think we'll find a lot of alignment on. We all want to be able to work in a system that has our backs. And for the people we serve, patients and their families, they also want to know that the system's here to support them.
So I wanted to give you an example. So here in Edmonton and other parts of the country, we've seen people being attacked for wearing the hijab, or there was a family that was killed in London recently by someone who amounted to like a domestic terrorist, essentially. So we're thinking about that as an example of bias, like kind of Islamophobia, or bias against people who are of that faith. What do you think like we should be doing to try to make that situation better?
Yeah, so for me, this issue of anti-Muslim prejudice is a very personal issue. I personally knew the family that was killed in this attack, and it's very deeply personal. But I've said very clearly, we need to name this problem before we can do anything about it. We have a hard time in Canada admitting that we have this problem. And I think this culture of denialism and avoidance actually is dangerous. It's dangerous for people like my family and I to deny it. And part of the problem is we see various forms of anti-Muslim prejudice manifest themselves in the medical system all the time. I mean, in surgery, if you think about what it means to be someone who wears a head covering and all the kinds of comments and experiences that women have. In one of our provinces in Canada, you cannot have a head covering and actually be employed in certain jobs. But we have to be willing to have that conversation if we want to do something about it. We can't fix what we can't name. And part of what we're seeing right now is tragically, it's this experience of our family friends that has opened people's eyes to the fact that, I can tell people very openly, since this has happened, my family and I aren't functioning in society without some level of fear. Every time we hear a car driving fast or we see a black pickup truck, we wonder, we're afraid. And I think that to me is a tragedy. And I hope that my fellow Canadians appreciate that there are some of us who are worried and wondering whether it'll be safe for us to take a walk. And for too long, we've struggled and we've had experiences that anytime someone brings them up or names them, it seems as though we have a harder time with the naming of the problem than the problem itself. And so I think that's a key part of how we move forward from here.
I mean, certainly, I think I've had some experiences where you see people doing something and they say they're doing it for a certain reason, but when you look underneath, it's a different reason. So we had a medical student a few years ago who was thrown out of an operating room because the nurses said that they wouldn't wear the proper head covering in the OR, and it turned out they were wearing some form of religious head covering that they wanted to wear. And it turned out that the OR actually had policies that would have allowed the person to put another covering on over the top and be perfectly sterile.
Well, thanks for that example, because I would say examples like that are happening in ORs across the country. And with that example, it's great to hear that there was some semblance of accountability, because sadly, the vast majority of stories that I hear, there's no accountability. In fact, many of the people who perpetuate these kinds of very explicit and discriminatory and exclusionary behaviors are still working and practicing. Many are actually leaders within organizations without any accountability. So I think this is a challenge for us, because we have to decide what's okay and what's not okay, and what we're going to hold people accountable for and not, if we want to move forward towards a kind of culture and system where we are open and welcoming, and this ideal version of who we are. We have to address the fact that this is not a reality for many people in this country, that many people who experience discrimination. We recently did a research study where we did a critical analysis of discrimination and harassment policies across Canada in medical schools. And what was clear from that is that the onus of credibility and proving the experience of discrimination is on the complainant. There's very little onus on organizations to be transparent and accountable about how they define these problems. Most of the time, I encounter people who experience these sorts of things. They're told by people within organizations to keep their head down, to not make a fuss. And they're told that if they were to make a complaint or speak up, that they would most likely be demonized.
You're told not to be a troublemaker, right? Not to kind of stand out. because then you'll be labeled as somebody who puts themselves first and puts the team last. And you have to what, go along to get along, essentially.
Yeah, it's also a huge tension, I would say, within people who have various immigrant experiences. Because I can tell you from my own personal experience, my parents did that, right? They put their heads down and they tried not to make a fuss. I think about this family that we lost and what they did. They came here 14 years ago for a better life. Salman, he was a physiotherapist. He was a health professional. And they went through the process of credentialing and recertification. And they put their heads down and they did their best and contributed to their community. And they were murdered because they were visibly different. So I think we have to really challenge ourselves to remember that our silence will not protect us. It won't save us. We can't keep putting our heads down any longer. The reason many people like me do that is because if we stick our neck out, we're often told, and I've experienced this many times, that we're not allowed to feel that way, that somehow we should be grateful for everything we've been given. And I think that that's a huge problem. Until we're willing to accept that that's a problem, we're not going to be able to make things better. And I think in particular, when you've got people who are visibly different or racialized, or the descendants of immigrants, and they speak up about problems related to racism, it's even worse. And I typically didn't and hadn't shared some of my own experiences because it feels like I'm centering myself, which is something I rarely ever want to do. But in the wake of what's happened in London, I think it's very important for people to know that if you're racialized and you speak up about racism, you actually get and experience a higher degree of harm and backlash than if you're not. Because the expectation is that you should be grateful for what you've been given by Canada, which I think is highly problematic. Just like you alluded to earlier, all of us have different experiences and we all contribute to the communities in which we live, but we also don't. And for us to have this kind of implicit expectation that if you're racialized, that somehow you've been given something that other people who aren't racialized haven't. Well, that's a fundamentally racist assumption, yet that's part of the fabric of Canadian society.
It's 2021 now, so there's no excuse for medical schools not to be addressing some of these topics. So what's your advice to medical schools to say, how can you help fix the problem?
So yeah, I've been teaching and talking about these topics in medical curricula for a decade now. And actually accreditation standards explicitly say that we are supposed to talk about bias in Canadian medical curricula. So I remind people that this isn't just something that we should be doing now. This is something that's part of what we have been expected to do as part of our regulators for a very long time now. But you're right that it isn't talked about. And that's because even as early as not that long ago, we weren't supposed to say words like racism or words like white supremacy because it made people uncomfortable. And so people tiptoed around these issues. But like I said earlier, we can't fight what we can't beat. So I do think that as many Canadian organizations are now recognizing that we have these problems, we have to move forward. We have to name them and truly be willing to recognize how we've been a part of the problem. Many organizations and medical schools fall into defensive postures, start to get self-congratulatory, talk about the things they do, the things they try to do. I think we have to start by admitting what we've done wrong. We have to start by recognizing the truth and the harm, and then work towards reconciliation and improvement. This isn't something that's a project. This isn't something we can expect racialized students or faculty to pick up and do the labor on. This is something that Canadian medicine needs to invest its resources in making better. Far too often, we in medicine have this, in Canadian healthcare in particular, have this culture where we kind of have projects and we expect people to do it off the sides of their desks. We live off of the goodwill and volunteer time of people. But this is an issue where we can't expect people to put in emotional labor without actually investing. So make that investment of resources, engage and involve people who are critical scholars outside of healthcare and medicine. My PhD is in education, which is not considered a scientific discipline. But I often tell people it shouldn't have taken me a PhD outside of my discipline to be able to begin to reckon and spend time with literature and scholarship on these topics. And I also think, in addition to resources and engaging with experts outside of our field, we have to, in Canadian medical schools, actually decide and hold ourselves accountable to clinical workplace cultures. So much of what we do in medical education, we talk about in classrooms or in theory, without remembering that most learning takes place in clinical learning environments. So we can do all we want about setting competencies and expecting learners, like students and residents, to be competent in various areas. But unless we start to ensure that faculty are further developing their skills in these areas, we're not going to tackle the problem. So much of what we're trying to do is built on the expertise of people who aren't faculty, and our system isn't designed that way. So we really need to address that gap for those people in practice and support clinical learning environments that are more inclusive.
Yeah, I think this is what's so difficult about the topic, because like the stuff that gets taught in medical school is what you should do, right? Like the official version for how you're supposed to behave. But then you're taught how you should really behave when you're out on the wards and when you're out in the real world. And to be honest, the things that are taught in medical school don't really stand up to scrutiny sometimes under that pressure of the culture. I mean, the culture basically eats everything for breakfast around here. So if your preceptor behaves in a certain way, you're probably going to behave that way as well, regardless of what you were told in medical school.
Yeah, I mean, I think, again, there's a couple of points I would draw actually from research we've done. The first is in terms of what we believe about ourselves, right? So we did this study where we looked at how do we reconcile biases between teachers and learners. And learners said we need teachers that can role model vulnerability. And we don't have that. Yet the teachers said, oh, we're good at that. We know how to do that. So I think there's a real sense of hubris and a lack of critical introspection amongst teachers. The second thing is, I think we have to resist dichotomization and zero-sum framing. First of all, yeah, this is enormous. It's a lot of work. I don't think that's bad news. I think that's reality. But we have to reframe that, because if our narrative is about how much work this is going to be, that's going to make people feel like this is too much. It's going to make them feel frustrated and helpless. And we found that just making people aware of their biases makes them feel helpless and frustrated, which is why we have to couple that with things we can do. Because the truth is, why should it be enormous to create a system where people can feel that they're allowed to be who they are? Why should it be enormous for us to have a kind of community or society where my kids and wife and I can go out for a walk and feel safe and welcome? That shouldn't be too hard. So I would challenge all of us to recognize that for this to feel difficult is kind of a privilege in and of itself, because it's something that we don't just need to do, it's something we have to do. But it's also something that every single person working in healthcare has to believe. We have to believe this is central to our values. And rather than dividing ourselves up into the people that do and don't, I think our work has really suggested we frame it as we are all stumbling through this one day at a time, regardless of our history and our experience. And we are all part of the problem, but we're also all part of the solution. There isn't a group that gets it and a group that doesn't, or a group that's better and a group that's worse. It's about really embracing our full human selves and recognizing we all want to be part of something where everyone feels that they can belong.
Our time's almost up. It's been a fascinating discussion. I was wondering, do you have any examples of systems that are doing this well, or medical schools that are doing this well, that we should try to emulate?
The secret sauce in a lot of this is what I call inclusive leadership. And that's when you have people who hold structural power within organizations that resist fragility and defensiveness and work to create spaces where, like you said earlier, this is the norm, where you cultivate feedback on how you can be better, where it's normal to critically question whether things are working or not, and where leaders create space that people feel that they belong. Leadership is a very important aspect of success in this work. And I think we really need to challenge ourselves to think differently about how we select, how we promote, and how we hold leaders accountable within healthcare and medical education.
Yeah. So last question is, where can we learn more?
Just Google it. Google resources, there's tons of resources out there. They're all available. Where can we learn more? Well, let's start by looking in the mirror at ourselves. Let's start by having conversations with ourselves, by challenging existing narratives within our personal and professional lives, by thinking about the narratives that demonize some of us versus humanize the others. There's tons of resources out there. The last thing I would recommend is to sort of read a book and know more. There's always going to be a curated set of resources, but I would resist the temptation to say, here are the things you can do. And I would say it's on all of us to do the work and to find the resources. There's lots of curated resources out there if you're ready to look and ready to act.
Well, thank you very much for your time. That was a fascinating conversation.
Yeah, you're very welcome. So